patient advocate. I work primarily with cancer patients, so families that are faced with a devastating cancer diagnosis, I help them navigate through that. I've been doing this for 2.5 years, and I come out of a background that is not clinical like Dr. Rochester, but I have lots of lay training in oncology with my multiple decade career in biotech. So,
Wow.
and I
So
started doing this after my own father was diagnosed with cancer and went through it personally. So that was my passion, to want to help others. So that's me.
that's great. And I think that's where I'm most familiar of, not that I'm very familiar at all with the profession patient advocates, but I feel like whenever I've heard it referenced over the years, it's been related to individuals going through cancer treatment and just needing an extra advocate in that process. So great. Well, below, as you had referenced, below you, I've got Dr. Nicole Rochester on my screen. And Dr. Rochester, tell us a little bit about yourself.
Sure. Thanks for having us. We're really excited to be here. I am a pediatrician by training, and I have had a health advocacy practice for 3 years. And similar to Dana, my transition from a 20-year career in medicine to becoming a health advocate was sparked by family. So my sisters and I were caregivers to our late father. And I was really struck, despite my years in the healthcare industry and working in hospitals as a pediatrician, it was still very difficult caring for my dad. And most difficult was navigating the healthcare system for him. And I discovered that I had some inside tricks, so to speak, and that my knowledge and influence as a physician turned out to be a benefit for my dad. But I was compelled to share that and be a benefit for others. So that's really what prompted me to become a private health advocate.
Wow.
And I primarily work with other family caregivers, helping them care for aging and disabled loved ones.
Oh, okay. So even though you're a pediatrician, your private advocacy approach is leaning more towards older adults?
Absolutely.
Okay, because I have to say I can imagine, especially families who have children with disabilities and issues like that. Man, talk about a place where you'd really want an advocate would be in the pediatric area as well. So
yeah, Steve, briefly, because I know we don't have a lot of time, but what I have found in my years of practice as a pediatrician is that parents are pretty tied in, and healthcare professionals that deal with children have a very different attitude. There's a much more collaborative, family-centered approach that I found was lacking for my dad and for other older individuals.
A great insight. Okay, and then lastly, below me is Myra Katz. And Myra, tell us a little bit about your background and how you came into this profession.
Hi, Steve. Thanks so much for having us. I'm a physician assistant forever. Actually, I graduated GW in 1978. So I was a PA until about 4 years ago, doing mainly oncology and hematology, and realized at that point how broken our healthcare system is and how people just can't get through the system well, and they're struggling. I dealt with my husband with cancer and many friends and realized that we needed something else. I burnt out in doing actual patient care and decided to transition to becoming an advocate. And I've been doing this for close to 3 years. I work with people with catastrophic illnesses, helping guide through the system. I also help people in end-of-life care because I'm very involved with local hospice and palliative care and helping people do their living wills, because people don't understand what it means to have actually a good death. We talk about it, but nobody gets it. And people die a very unhappy death often, and families don't understand it. And we can make it better, and we need to.
Great. All right. Well, this is I'm really excited to hear the insights that the three of you are going to provide our audience with. As I'd mentioned, questions have already started coming in, and I will, if there's an appropriate opportunity, I will break in and maybe say, hey, we've got a question. Like, for example, Diane Watson has already typed in a question. Have you heard from patients' families that they felt that COVID interrupted the treatment plan that they had started before COVID? So you don't have to answer that right now, but I just want to give you and the audience a taste for the fact that we want to make this interactive. So I'm going to go behind the curtain. You might hear my voice, but I'll let the three of you take it away from here.
Thank you, Steve. And I think just to give everybody sort of an idea of how the three of us had looked at how we were going to do this panel is we're going to try to answer as many questions up front through case studies. So we want it to be interactive. So if you could hold questions, Steve, maybe, unless there's an obvious break, until afterwards, where we've built in time to answer questions at the end.
Awesome.
So at this point, I'd like to just go ahead and pass it over to my colleague, Myra Katz. And I'm sorry, not Myra. This is for Nicole, Dr. Rochester. She's going to give us just an overview of the landscape of private patient advocacy today.
Thanks, Dana. So again, welcome to all of you. We realize that some of you may be intimately familiar with what a private or independent patient advocate is, and some of you may be hearing this term for the first time. So we wanted to spend just a few minutes kind of giving you an introduction to who we are and what we are. So a private or an independent patient advocate is a professional knowledgeable about the healthcare system whose job is to help patients and their family caregivers navigate this complicated healthcare system so that they can receive appropriate and effective medical care. And just a quick note about terminology, you'll hear us perhaps interchangeably use the word private patient advocate, independent patient advocate, or health advocate. Those terms are all interchangeable, but the word private and independent is really important, and I'll get to that in just a moment. So we have varying backgrounds, as you've already heard with our introductions. Many private patient advocates have a background in healthcare. We are physicians, we are nurses, we are physician assistants, nurse practitioners, case managers, pharmacists, insurance industry experts, medical billing experts, but that's not a requirement. And there certainly are some private patient advocates who, as we've each shared, have just had a very intimate experience, often negative, with the healthcare industry, and they have used that personal experience to fuel their desire to go out and help others. So I want to talk a little bit about private versus employed so that you can start to get an understanding of how we are different and unique from some of the other professionals, and Steve even referenced this earlier. So the key with being a private or an independent patient or health advocate is that we work for the client. We are self-employed individuals. We have no allegiance to hospitals, to other healthcare facilities, to insurance companies. And that becomes very important if you consider some of the other professionals who may do some of the same things that we do. So just as an example, a hospital advocate, patient advocate, that person is great, but they work for the hospital. And so their primary allegiance is going to be to that hospital. And in that setting, those individuals often are employed by the risk management department. So interestingly, their job really is to mitigate risk and to protect the hospital and not the patient. We can also talk about hospital case managers, which are often also amazing, and hospitals literally could not function without them. But their primary role is to facilitate discharge. And again, they are employed by the hospital. So when they are making recommendations, regarding facilities or post-discharge care, sometimes they're limited in the recommendations that they can give due to their allegiance to the hospital. We have patient navigators, which I think is what Steve was referring to. That is what you often see in the oncology community. And again, they are amazing, but they are usually limited to that one department within the hospital. So in contrast, we work broadly with our clients. We do all kinds of things, from helping our clients locate healthcare providers to helping facilitate second opinions to we facilitate communication between the medical team. And I'm sure all of you have witnessed that there's often a breakdown when there's more than one doctor on that medical team. They don't talk to one another effectively. And so we bridge that gap. We attend medical appointments. We can provide support at the bedside, in the ER, in the hospital, and even in skilled nursing facilities pre-COVID. We can help our clients explore treatment options. We can help with medical billing, insurance appeals, end-of-life care, advanced directives, and so much more. So our scope of practice is very broad, but it's specifically dedicated to helping our clients navigate the healthcare system. And we're going to share some specific examples of that as we move through the program. So on that note, I'm going to go ahead and hand it over to Myra.
Hi, thank you so much for having us. I'm going to talk today about something relatively new that we've all heard about and may be frustrated about, and that's telehealth slash telemedicine. They're sort of interchangeable. Actually, telemedicine is for people who live in distant areas. The doctors come in from, maybe if you live in Alaska and you can't read an x-ray, so they've got somebody from Omaha reading the x-ray. So it's a different thing, but we're going to use telehealth to describe what's going on now. I could talk for hours on this, but I'm going to try and just give you the brief scenario so you understand what's going on. And I'm going to give you a little case study and teach you about it so you can prepare yourself for what's going on today. For years, many people have wanted telehealth or telemedicine because they get tired of sitting in a waiting room, waiting for the doctor, missing appointments, having to sit in traffic, and they get really annoyed. And doctors would like it because it's easier for them, because when they have to make phone calls, they miss their appointments, they don't get paid for it, and it's frustrating for them. So now fast forward to COVID, and we have telemedicine, which is being paid for by many health insurance companies, but it's still a work in progress. The problem with COVID is that many appointments have been canceled. Doctor's office have canceled them, and when they do open up, they're only 50% of the time, so people can't be seen. And you know that many of us make appointments 6 months in advance, so what happened to those appointments? Where do they go? And they have to be filled somewhere, but if you do the math, it can't be done. Now, I'll give you a little case scenario what happened to my husband. He has a history of atrial fibrillation and sees a cardiologist every 6 months and is well managed. He was supposed to go in mid-May, and unbeknownst to me, the office called and said, "Can we make your appointment at telemedicine?" He said, "Sure," and told me after the fact. I took a deep breath and said, "You're really lucky you're married to a patient advocate, because this would not work otherwise." And I sat down and wrote down my questions and what the goals for the visits were. We get on the call and it's delayed because the doctor can't figure out how to set up the computer, which is one of the problems with this telehealth. You need technology and some people can't use it. So we ended up just doing a phone call, and the doctor was unable to access any of his records, any of his medications, or any of his history. So fortunately, I had it all written down and it was in my head. So the doctor started just asking him how he was feeling and how he was doing and how his medicines were, and was ready to say, "Okay, I'll see you in 6 months." And I sort of interrupted him relatively politely and said, "I don't think so." Told him that I thought that having AFib, he needed an EKG, he needed to be seen, he needed his heart listened to, he needed vital signs at the very least. The doctor kind of shrugged, said, "Yeah, I guess so." But we left it open-ended that he was going to call the lab and set up an appointment to get this done. Fast forward, he ended up getting his internist to see him for a physical, and it was all taken care of. But if it wasn't, he just would have been put aside for 6 months, supposing he was having problems with his medications. It's not working. And if you don't know what you're doing and you get intimidated by the doctor, especially, it's a lose-lose situation. The doctor loses, but really as a patient, you lose, and you need to take responsibility and be able to ask questions and not be scared. And that's what we all are. Many of us are afraid to open our mouths to ask questions, and it's a problem. So the issue is this does have limitations, but we can make it productive and make it worth our while and get goals. What we also think, this is great. I can take this appointment, I can sit in my pajamas, I don't have to do anything, but be prepared for your visits because it's so important. I had a heart attack 2 years ago, and I was the secretary called me up to reschedule my appointment. And I said, "Do you think that's a good idea?" She said, "Well, no, but we just can't see you." And then I said, "Is the cardiologist aware that you canceled my appointment and you're not seeing me?" She said, "No." I said, "Well, I've got to be seen, so if he can't see me, I'll see somebody else." And she got rather indignant and said, "You have to be seen." So I very nicely said, "Well, figure it out. Otherwise, I'll see somebody else, because you can't tell me I have to be seen and not see me." So how do you make it work? How do we make this happen? And you need to know as a patient what you need to be seen. So there are certain specialists that we can do telemedicine wise if we have an appointment with a relationship with them. For example, if you've got diabetes and you have to get a follow-up appointment, fine. Make sure before you go for that visit or your telemedicine that you have an A1C done so they can check your blood sugar, see how they're running. You need to check your own blood sugars. You need to have a list of your medications, and you need to be able to see your doctor, and they need to see you so you can show them your feet. Because we know when diabetics have bad feet, so you can make it a worthwhile visit if you can do all these things. And one benefit too of a diabetic person specifically, they can look around your house. They can say, what's in your refrigerator? What have you been eating? So you can make it a better visit than just sitting in the office. So make it to be what you want out of it. You know, we can do it, but we need help with our providers. Other thing is non-emergencies can be done telemedicine, but you need to be triaged. And by that, I mean, somebody in the office has to talk to you and say, what's going on? Let's see if you need blood work. Do you need to be seen? And if you don't need to be seen, how do you do it? Or if you are seen, how do we make it work? And they need to make sure that when you do come in, you get your labs done and that you make sure the office is good for you, that maybe you make a phone call before you go in the office, and there are very few patients out there. Acute problems have to be seen. For example, if you have a heart problems and you've got shortness of breath, chest pain, swelling of your extremities, a new lesion on your arm. Again, triage, and also ask who's doing the triaging. If it's a receptionist, say, can I talk to the nurse? Can I talk to the doctor? Can I talk to the mid-level? Because I'm going to tell you a little secret, and that is most people, most providers, and Nicole can definitely test this, don't have any clue what goes on at the front desk. They have no idea who's saying, we don't want to see you. And when you do call in, get the name of the person you're talking to. So you can say, Nicole told me I can miss my appointment for 3 months, as opposed to, oh, somebody will answer the front desk. You personally, as a patient, become more reliable, and they're going to listen to you more than just someone who says, oh, I just called down who I talked to. So that's just a little aside. Another thing that you should keep up with is your annual visits, because they're really important, particularly for cancer screening. And they want to make sure you get your immunizations taken care of. So try not to avoid your annual visits. So if you do have telehealth, what do you do? How do you make sure it works? As I said, get your questions in order. See what your different options are. Are they phone calls? Are they Zooms? You know, one thing, if you can see the doctor or mid-level nurse, they can say, show me your hand. Let me see you get up from your chair if you say my hip hurts. They can watch how you're moving around. Do a couple jumping jacks. Let me see you move your head side to side. So it's a benefit of the telehealth appointments that we can do it. And if you are going to do telehealth, another thing is find a quiet place to do it. Don't do it in the kitchen with your kids running around. If you don't want your spouse opening up their mouth and saying, he's lying, he just ate a bowl full of ice cream, or he can't make it up the steps, then go in a separate room. Or if you want your spouse there, it could be very helpful if they can help you. But one thing I forgot to mention that's really good for telehealth is mental health. And a lot of mental health providers are providing this. Your provider, your office, sometimes work will provide it for free, but mental health is extremely important, particularly in the day of COVID, and we can do that virtually, and that's very vital to do. Now, I've just touched on the surface. I could go on, but I can't. But there's lots of different things, and there's articles and papers, and there'll be some places to reach us at the end. I'll be more than happy to help you get through your telemedicine appointments. Because the other one thing to do is, you can have your advocate on your teleappointments. I've been on many, and it's become much more goal-oriented, and all of my patients I've done it with have walked away, and the doctors have too, saying, this is a great visit. So now I'm going to bring you back to Dr. Rochester, who's going to talk about hospitalizations in the time of COVID and beyond. Thank you.
Thank you, Myra. So you've heard how, having a health advocate, Myra gave an example of her husband, and because Myra's a health advocate, she was able to completely steer her husband's telemedicine appointment. And these are the same things that we do for our clients. So the case example that I wanted to share with you all has to do with a client that I worked with at the very beginning of this COVID pandemic. Excuse me. So I got a call from a small employer in Virginia back at the end of March. And they were, the despair in this professional's voice was palpable. And basically she said, we have an employee who is at a small community hospital here in Virginia. He has COVID. He's in the intensive care unit and he has no idea what's going on with him. They're not communicating with his wife. His wife is afraid that he is going to die. And we want to hire you to help this situation. And their primary ask when they reached out to me is that we want you to help us get him into a tertiary care or an academic facility. So we immediately got on board. They retained me. I reached out and within a few minutes had the charge nurse on the phone. From there, I was able to talk with the attending physician. I spoke with the patient who became my client, and I spoke with his wife. And we just had some amazing conversations. And I just started at square one, what is actually going on? And what I quickly discovered, and this has been the case with just about every client that I've worked with, is that a lot of times the communication gaps and the communication barriers lead to misinformation, lead to really sometimes unnecessary concern. And so in this case, I spoke to the client and he explained that he had been hospitalized for a few days. He had all the classic COVID symptoms. He did have some respiratory distress. He was requiring oxygen. And his concern was that this is back before we knew better or more. He really wanted to get hydroxychloroquine, and the hospital at this time his impression was that the hospital will not give it to me. And so that was just one of his many concerns. He also felt like the medical team really wasn't communicating with him. He was very concerned that he may have been sicker than what they were letting on. And so that was his concern. When I spoke with his wife, she basically hadn't received any information about her husband's hospital stay. She knew that he was in the hospital. She knew that he had COVID. But beyond that, she had had a significant difficulty getting the nurses to talk to her, getting the doctors to talk to her. And so she was just sitting at home alone, terrified that her husband was going to die. And so then I reached out to the charge nurse for that unit and got a much better understanding of his hospital stay and what had transpired thus far. And from there, I was able to get in touch with the attending physician. And what I learned through those conversations is that, A, this patient was not in the intensive care unit as his wife and as his employer had thought. He was actually on a regular medical floor on a couple of liters of oxygen. And so that that immediately kind of changed the whole slant, because again, their primary ask was he's in the ICU, they're not taking proper care of him, and he needs to be transferred to a higher level of care. What I discovered is that while there were absolutely some significant communication gaps, you all know that with COVID, there's no visitors. So, and at that time, March, early April, the hospitals were really struggling to manage patients with COVID. And so the communication had completely broken down. They had not yet established good methods to reach out to family members. And so that part was absolutely true. But in talking to the physicians and the nurses on his team, I discovered that he actually was receiving appropriate medical care, and that in fact his concern regarding the hydroxychloroquine, just that morning the hospital had secured a supply and he had already been started on that particular medication. So, I circle back to the client and to his wife and to the employer, and literally within less than 2 hours, everyone was breathing a sigh of relief, just knowing what was actually going on with him, knowing the treatments that he was receiving, understanding that actually he wasn't in the intensive care unit. So I was able to not only provide that peace of mind and that information to my client, to his wife. I interpreted everything and put it in lay terms. That's another common thing that we do as health advocates. As a physician, I am intimately familiar with all of the, medical lingo, but we know that our clients don't have that background. And so that's one of the things that I love to do, is to take very complicated medical information and just distill it down for my clients and for their families. And so in doing so, it just provided a sense of relief. They understood what was going on. And then we determined as a team that he actually did not, at that point, need to be transferred to a higher level of care. He was getting appropriate care where he was. We established some parameters that would determine when he would need to be transferred. And I developed open lines of communication. The physician and I talked at least twice a day. I was able to, follow up with the client and his wife, and it all went incredibly well. And within 2 to 3 days of me having contact with that client, he was discharged from the hospital. Now, at the time of discharge, as a health advocate, I was able to be present virtually. And through his discharge process, many of you know that that is a very difficult time for patients and families. It's another source of miscommunication, faulty communication, and we did identify some gaps in his instructions. So with me being there on his cell phone, sometimes we'll do it via Zoom, but in this case, I was on speakerphone on his cell phone, and I was able to identify gaps in his discharge plan, and I was able to be his mouthpiece and to ask questions of the nurses and of the doctors to make sure that my client and his wife knew exactly what they needed to worry about when he went home. With COVID, we know that there have been patients that have been discharged and then they've had rapid decline. So knowing that, I wanted to make sure that that was discussed in detail as he was being discharged from the hospital. He was discharged on oxygen, so I was able to help facilitate that process. About 2 weeks later, when he no longer needed the oxygen, he called me up because they had no idea how to return the equipment. So I was able to facilitate that and reach out to the home health company that supplied the home oxygen and arrange for someone to come out and pick up his oxygen. So it was just a wonderful experience for me, as well as for my client, for his wife, and for that employer. And so I really just feel, I guess what I really want to explain to you all today is that certainly, we are useful in and outside of COVID. Prior to COVID, there have been all of these issues that we are describing today, but certainly the pandemic has really shed a light on those things, and it's made many of the problems that we already have in our healthcare system even bigger. So my opinion is that now more than ever, your clients will absolutely benefit from having a professional patient or health advocate by their side as they navigate this complicated healthcare system, whether they have COVID-19 or not. I think, being in the hospital, we all know, is incredibly scary. Things move quickly. A lot of times patients are not aware that they have choices. They are afraid about asking questions. They don't know how to properly escalate their concerns. And these are all things that independent health advocates can help facilitate. So I hope that's been helpful. That's just a little bit about how we support our clients during their hospital stay. And now I'm going to turn it over to Dana, who's going to talk more about assembling a healthcare team.
Thank you, Nicole and Myra. And I'm hoping that y'all are starting to see a theme here that probably the biggest thing that we bring to the table is just a peace of mind that you have when you understand what's going on and you become more confident. And that's what we all want to do, is to empower our clients to really fully understand what's happening so they can make choices for themselves with confidence and with a peace of mind. It's just as important or another thing that we do that's just as important is assembling the right team for your healthcare, and whether that varies depending on the goals of the client, right? So if you have, the first thing we do is we ask the clients, what are their goals? What do they want? Not everybody wants to be involved with research. Not everybody wants to go to a big academic center. Some people want to stay home. They want to be in their community hospital. They want to be around their support system. So it's very important that we are not directing the care. We are helping them to articulate their goals and what their objectives are. In some situations, it's vital that the right healthcare team be put together. So I'm thinking of diseases that are very specialized, like multiple sclerosis or Parkinson's, or a lot of my cancer clients. In some instances, it's really going to benefit the client if they have a very expert team. put together. So I wanted to just give you guys an example of how I recently helped a client in the middle of COVID. It makes it a little more difficult because access to a lot of people, travel is limited. A lot of the clinics were actually not seeing people in person. People were not able to get biopsies. It was kind of a big mess. And I had one client up in the Northeast who had a very rare cancer, who reached out to me, even though she was in an academic center that is all very well known in the Northeast. She didn't feel like she was actually being presented with the most innovative options or the best options, and she was very astute on her own. She was a researcher by trade, and she felt like she was seeing all kinds of things on forums, and she just didn't feel like she was being treated properly. After talking to her and understanding that her goal really was to be presented with every innovative option out there so she could make a decision on what she wanted to do, I quickly tapped into my personal network. I located the person that was on the East Coast that had the most expertise in her particular cancer, as well as somebody on the West Coast, so she could have both options, presented them to her. She said, go ahead and move forward with both of those people. So I reached out to them through their personal email that I have. So I didn't have to go through the contact form, contact me here at this, and you never get through, and you talk to some biller somewhere and some scheduler who doesn't understand. Was able to send them personal emails requesting that they would consider seeing my client. So through that, they rearranged schedules, and actually now she had on her team an expert pathologist who was very well versed in her particular type of cancer, as well as a researcher / clinician at another major teaching institution on the East Coast. So they agreed to see her case. That was the good news. But then we have a whole nother set of issues of getting her data out of this one academic center into these other two centers so that it could be reviewed. Because she was not going to travel and she was not going there on her own, we had to make sure, to Myra's point, we were going to have a telemedicine appointment. So every piece of information needed to be in their hands prior to this meeting, because I didn't want to waste this opportunity for her. So it took a lot, but it takes knowing the right people to call, how to talk to people, what you're asking for, the pieces of information that were actually necessary versus the pieces of information that maybe we didn't need to waste time getting to them on a stat sort of situation. And it took a while, but we got all of the information, scans, images, medical reports with doctor's notes, not just things that were on the patient portal, but the actual doctor's notes in the hands of these two specialists so they could do a thorough review of her case. She then invited me in with her consult. We did some preparation prior to the consult, just so she would have her questions ready. She would know what her objectives and her goals were for the meeting. And we had a very interactive, very productive consult with both the pathologist as well as the other specialist. It resulted in her feeling confident that there were clinical research options for her, that there was innovative therapy that she could be considered for, that she just wasn't getting from her prior institution. Now, she didn't want to leave her prior institution because of the logistics of COVID. She, was close to home. She lived in Boston. She needed to stay there. So what we were able to do was have these two specialists who knew some of the team where she was already being treated to agree to collaborate. And so we have a very collegial situation happening now with this pathologist and this other oncologist and then the team that she already had. And mind you, they're all from different healthcare systems. So it may not have happened if the client had just been doing this on her own. It took some of the facilitation skills of a private advocate, as well as just the knowledge of how the system works and how to get these people to all talk to each other. And now she has a very supportive team of people inside and outside of the system where she is. She feels new hope. She feels empowered, and she is moving forward with her treatment with much more confidence than she had before she engaged my services. So that's just an example of what we bring to the table. And for the most part, I feel like for my clients, it's the feeling of peace that they have and confidence that there's a professional on their team that's helping to guide them, just as we ask for professionals. I mean, I would not trade stocks by myself. I mean, I ask my professional to come help me, and we do that for clients. So that's just an example of how you want to put together your team and how a private patient advocate can help you put together the best team to reach your goals or your client's goals. And with that, I would like to turn it back over to Dr. Rochester, or excuse me, no, to Myra. Sorry, Myra, who is going to give us an idea of, this is great. We've seen how a private patient advocate can benefit a client, but when do we know when to hire one? So Myra?
Okay. Thanks so much, Dana. That was very informative. The question here is, when do you hire a patient advocate, or how do you know? And there are a couple simple questions to ask yourself and a couple of things to think about. If after your visit or phone call, you feel you're not getting your questions answered, or you have more questions than when you started, you need to think about hiring an advocate. Or if you've just been diagnosed with a horrible disease and you don't know where to turn, and Dr. Google Aunt Joan isn't there to answer your question, then maybe you should think about it. We as advocates aren't emotionally involved, and we can ask the important questions. We can take the right notes. We don't lose track of what the doctor or provider is saying, because we're there to be there for you. And we can prepare you for your visits and make sure that they're productive. So if the answer to any of the following is yes, you need to consider an advocate. And as I said, one is, do I have more questions than I had after my visit than when I went in? And that's a clear sign to say, hey, maybe I need to talk to somebody else. Am I having trouble getting past the front desk? As we talked about, it's real hard. Dr. Rochester and I can sort of we know the tricks on how to get through, and Dana's been through the ropes a lot too, so we know how to get through, but we can teach you how to get through, or we can do it. I mean, we're all pretty good at it. And as a consumer or patient, you don't know what to do, and you get intimidated often when they say, well, we have no appointments or whatever. So that's an important time to say, maybe I need somebody else to help get me past this person taking the phone call. Am I unsure about the treatment plan they're giving me? That's a real key. If you don't know what you're doing, or you don't like what they're saying, or what you read is different than what you're told, then get somebody to help you. Because as we said, this is not your business. This is not what you know. You don't understand it. So we know, we understand it. We can't do it. We ask one of our friends, one of our fellow persons to help us. And again, if I've got a serious or terminal illness, I don't know what I'm doing. I don't know where to go. I hear this is good or that's good, and I'm just lost. And one thing to remember is, often most advocates will offer a free consult. It may be a few minutes, but you just get an idea by talking to somebody. You'll get 10 or 15 minutes and look online, look us up and just see what we say. Because often we'll say, yeah, it's free, and we'll tell you whether we can help you, whether we can't help you, and give you some ideas on what to do. The most important thing to remember is specialists don't talk to each other. Believe it or not, your cardiologist has no idea that your orthopedist has given you this medicine for your back pain, which you shouldn't be taking if you had a heart problem. So your advocate can be your quarterback. And it's so vital, because they just don't do it. They don't have the time, and they just don't have the wherewithal. And that's where we come in. And I'm going to send it back to Dr. Rochester, who will help talk about the average cost, or how to determine the cost of your advocacy, private advocacy.
Thanks, Myra. So yeah, you all have heard all these amazing things that we do. I'm sure in the back of your mind, you're wondering, how much is this going to cost my clients, the people that I work with? And if I want to refer someone to a health advocate. So, Myra already touched on the fact that most of us will offer some type of initial contact with your clients for free. Most of us will, whether it's 10 minutes, 15 minutes, I do a 30-minute consultation just to really hear the story and find out if we're even able to help. And if not, as Myra alluded to, we have a vast network of other health advocates in our community and beyond, and so we can refer. But to answer that question, I guess, I'll answer the question with a question. I am going to answer it, but is there really a price that you can put on the types of things that we described? And my answer would be no. I mean, in reality, these services truly are priceless, but the cost of a private health advocate is going to vary. And that's going to vary depending on a few things. It's going to vary on your geographic location. So what you pay for a health advocate in DC is going to be very different than what you pay in, some small town in Kansas, which is going to be very different than what you pay in California. It's also going to depend on the professional background of the health advocate. And so, depending on their skills, depending on their years in practice, depending on their professional background, their degrees and things of that nature, you may see some variability there. And then it's also going to vary depending on the scope of practice. But as a general rule, I have seen health advocates charge anywhere from $50 an hour all the way up to around $400 an hour and everything in between. So that may not be extremely helpful for you all. I guess what I would say is that, it's very important first to find an advocate that is a good fit, and then to have those discussions about cost. Also, we know that many patients and clients who really need us are the ones who can't afford, unfortunately, to work with us. So we also will often put clients in contact with free resources and other things in the community if they are unable to pay. You all probably know this is not covered by health insurance, so this is an out-of-pocket expense. But like Dana said, we pay for lawyers, we pay for financial professionals, we pay for accountants, and certainly our health and the health of our loved ones is equally, if not more important. So now I'm going to turn it back over to Dana so she can talk with us about how you find us.
Thanks, Nicole. So there are a lot of questions. I'm noticing we've got a lot of questions. Some of them I'm hoping that we have answered for you. One of the ones was, how do you find us? How do you find a private health advocate? Independent health advocates right now, this is a relatively new profession. So I'll just say that. All of us have websites, so you can find us that way, but just by Googling. Some of us have better SEO than others. So Google might find us, might not. But one of the other places, I'm going to give you guys a couple, and I'll type it in the chat here in a second, but there's several directories that are out there that are attached with advocacy organizations where the people, if you are listed on a directory, you're an advocate who has insurance and has been vetted, so you actually have a valid business and you can do what you say that you can do. And some of them are, I will mention just the National Association for Healthcare Advocacy, the NAC. They have one, and theirs is nahac.com. They have a directory. There are Greater National Advocates. They're located out of Chicago, and they have a directory that's nationwide. All of these directories are nationwide. You can find people in any part of the country. That's gnanow.org. Then there is AFA. The AFA is one of the earliest organizations to really propel the profession of private advocacy, and it's the Alliance of Professional Health Advocates, and they have a directory called the Advo Connection, and you can find that at advoconnection.com, and there's a directory there. And then we also have, if you're just interested in the policy of patient advocacy, and many of you that are on this call are working with patients and clients in assisted living and nursing homes and hospitals, and there are so many of you out there that are doing such great work on behalf of clients. The National Patient Advocacy Foundation is more of the government affairs arm of our organizations, and they are doing a lot on Capitol Hill for just policy for patient advocacy. So that might be something you want to check out. And so that's how you find us. I don't know. I think now I might want to just, Nicole, can I throw it back to you for a second to go ahead and just give a definition of the difference between, say, a geriatric care manager versus a private patient advocate?
Sure. Yeah, we know that was one of the questions. I mentioned earlier some of the other advocacy professionals and how we differ. I guess I would say that, we probably are the most similar in some ways to geriatric case managers or care managers, also known as aging life care professionals. The main difference in my opinion, and from what I've read, is the scope of practice. So, in both cases, well, as you've heard us talk about today, while many of us focus on aging individuals, that is certainly not the focus of private health advocates in general. And so, there are some of us that work specifically with cancer patients like Dana. There are some who work specifically with end of life issues. There are some who work specifically with a single diagnosis, mental health. So, I think that's really the difference, is kind of the breadth versus the depth. And we specifically focus on healthcare and navigating the healthcare system. So aging life care professionals will, they may do other things related to social, related to community. And it's not to say that we don't do that. In fact, when we're working with our clients, we tend to delve into those areas as well. But our primary focus as patient or health advocates is the healthcare of our clients and making sure that they are navigating the healthcare system appropriately, making sure that they have the right teams and all those other things that we've talked about with you all today.
Thank you, Dr. Rochester. I also just wanted to add one thing. I mean, I've seen in here just different questions about, do the insurance companies pay for your services, and are you well covered by insurance? And on first blush, right, you kind of think, oh, darn, no, we're not covered by insurance, so it's an out-of-pocket fee for the client. But if you really think about it, your clients really don't want us to be paid by the insurance companies, because if we're reimbursed by the insurance companies, guess what? We are working for the insurance company, and then you're working to mitigate costs. And, it might not behoove the insurance company to know about a clinical trial in Seattle when their people are in Wisconsin, and it gets messy. And so I've actually been contacted by several of these big AI companies that are putting together algorithms for insurance companies, and they're looking for advocates to come help their clients understand the reports and to be able to understand what they're asking, the different options. And I'm finding that every time the options are not necessarily geared towards giving the client, the patient, the most information. It's trying to actually take choices away from them so it won't be as expensive. So you don't want us really to be working for the insurance companies. I'm looking, do you see any other questions here, y'all, that you would like?
Hey.
So many, Steve. So many.
Yeah. Well, let me kind of go through a few. Like you said, a lot of the ones you've answered, we've gone over pricing. But let me just kind of go down the line here. M. Newell says, to get hospital and subacute discharge planners to inform folks of this option. Yeah. So I'm assuming so if somebody hires you and they've entered the hospital, how do you work with the case managers? I imagine you could be a headache to case managers, but you could also be a godsend in that you're working on the discharge, which takes that off of their plate.
Mm-hmm. Yeah, you're exactly right, Steve. I mean, I think in general, with healthcare professionals, we often are either the headache or a godsend. And I think part of our challenge is often getting them to understand that really we're a godsend, but we try our best to work collaboratively with the hospital professionals, and not, we don't develop antagonistic relationships. And I work a lot with clients in hospital settings, and I have found that first conversation that we have with the physician, with the nurses, with the case managers really sets the tone, because most of them are kind of, they're on the defense and they're wondering, who are we? Why are we here? But yeah, we do work collaboratively, with the case managers in the hospital. But like Dana said, sometimes our recommendations may be in direct contrast with what the case manager has recommended. And also sometimes, their job is to facilitate a timely discharge. So we may step in as an advocate for our client and realize that this discharge plan is just not appropriate, and that may actually delay discharge. But we certainly do our best to work collaboratively with our partners in the hospital system. And I have found that 99 times out of 100, they are deeply appreciative of our involvement.
I would agree. And I actually, I always introduce myself when time permits. Sometimes I don't deal necessarily with clients that are like going into the hospital emergently. People usually find me before that happens, but I always introduce myself to their healthcare team. I supply the HIPAA form. I tell them what my role is, and that I'm there to help them too. And I've actually gotten recommendations from, oncologists that have like written reviews positively for me. So we definitely can help because the system is stressed, and anybody that can come alongside and help alleviate some of that stress is a good thing. I also warn on, I don't often call myself an advocate. I just find that vernacular sometimes has a negative connotation. People feel like, why do they need an advocate? What's wrong? Like, why do they need somebody to advocate? And so a lot of times I'll just say I'm an independent healthcare consultant, or I'll say something else that's just so they don't have this negative perception right off the bat.
And you may have touched on this, but there's a couple of questions, one from Betty Bahardoui and Tyrus Madden. Is it regulated, and is there a license or certification required? And if not, what are the necessary qualifications?
Dana or Myra, one of you want to take
that? So there is a certification. This has recently become certifiable, the right word. But we do have a board of professional advocates that does put out a certification, and many of us are certified. So yes, there are credentials, but then there are plenty of people that are practicing that have not gotten the certification that are more than qualified to be a patient advocate. Nicole, do you want to add, or Myra, do you want to add anything to that?
I think the thing too is that almost all advocates have insurance, and you want to make sure that we've been vetted and that we do carry our own insurance. You don't want just somebody who said, well, I want to be an advocate because I took care of Aunt Jean once. You want to find out what they do. And I've been vetted. I'm sure you all do. And I've gotten private insurance. And that's a very important thing. In order to be listed in some of the websites, you have to have been vetted with insurance.
Okay, great. And yeah, I mean, so many times in new professions, you know, this period of kind of regulation and certification and insurance and bonding. So it's just like you guys are advocating for your clients, you know, when we're recommending a patient advocate to our clients, make sure that you do a little bit of digging around there as well. Jane Buchanan, and you touched on telemedicine, but Jane Buchanan says, do you think some of these new apps like IC-Med, we've been featuring a lot of these sort of communication apps, can help advocates and family coordinated healthcare issues? I guess personally, is there some tech that you guys are using that kind of brings the family together and assists you in being a patient advocate?
I haven't personally used any of those. Have you, either of you?
I have not. I am familiar with the apps, and I try to, you know, understand how they function and how they're different so that I can at least make them available to my clients. I guess I'm still somewhat old school. And so, you know, I kind of see that as my role. And so I am personally bridging the communication gaps, and, you know, we'll send secure emails and things like that to make sure that the family members are on board. But I do think that there is a role for those apps, particularly when there are a lot of family members involved, particularly if there's this, you know, vast geographic distance between them. But I personally have not used them either.
Okay. This is a good question from Linda M. that we could do a whole probably 2-hour session on. But with COVID blocking so many visits, how do you gain access to your patient's facility?
It's individual. I mean, you have to talk to the facility. I think now in California, there's a law that states if somebody has any kind of diminished faculty, dementia, it could be forgetfulness, whatever, special needs, they have to have somebody with them in the hospital. I think those laws are going to be coming across the country. I think you can soft talk your way into many places. I'm sure Dr. Rochester has.
Yeah, well, the other thing I'll add is that I've worked with several clients during the pandemic, and I have not personally visited them. I have really been able to be a very strong advocate remotely through telephone calls, through Zoom calls like the one we're on now, where I can physically see my client, they can see me, the doctor's in the room. And in fact, that's what allows me to practice, in a location that's not limited to where my physical location is here in Maryland. So I think, that situation is going to be different. Certainly there may be some occasions where you really do want or need your advocate at your bedside, but I have been able to work around that during COVID. And I think many of my colleagues have as well, just because we don't have a choice in many cases.
And I know it, there was one of the questions that came in earlier, and I agree with both Myra and Nicole. And I work nationally. I work internationally. I had a client in London. So technology has really enabled us to be able to be very powerful advocates, like Nicole said, even from afar. There was a question that came in, Steve, before, asking about bedside advocacy and what to do, in the hospital. And I have utilized some of the hospital systems, if they have appropriate personnel and staffing, they have sitters. They will have somebody, it's usually a technical person. It's not one of the clinicians. It's not a registered nurse, but they do have somebody that you can ask to be sitting in your loved one's room, to be sort of watching the monitors, watching alarms, watching, being their voice in the room. So there is a way to do it. It's just sometimes you have to be creative.
Great. Two good questions for Dr. Rochester here. Audra says, do you think that there was an easier access to medical staff since you're a doctor? So the concept, I think most of us realize that the staff in the doctor's office is the gatekeeper, and that's all we can talk to. And then Claire asks, how do you quickly get the release of information from a client when he was hospitalized so that you could talk to his care team?
Okay.
Mm-hmm.
Yeah, those are both great questions. As I alluded to in my introduction, the short answer to the first question is yes. I mean, that's fortunately and unfortunately, that was my experience with my dad. As a caregiver, I was ignored, I was dismissed. And once I started telling them that I was a physician, all of a sudden the Red Sea parted. And so I do use that to my advantage as an independent health advocate. I don't like that this is true, but yes, when I call and say, I still say I'm a health advocate. I say, this is Dr. Rochester. I'm so-and-so's health advocate. I'd like to speak to the attending physician. And almost without fail, I either get patched right through, or I get they get a message to the doctor and I get a call back very quickly. To answer the second question about the HIPAA authorization, again, like Dana mentioned, where everything is electronic. So I have that form available electronically. And so in this case, what I did is I emailed it to my client. Thankfully, he was, conscious. And so he was able to pull it up and sign it through another app that I use. And then we were able to email that directly to the nurses station so that they printed it out and put it on the front of his chart. So that's something that took less than 5 minutes.
And I will just add, Steve, I'm not a physician, but just by saying that you're somebody's independent private health advocate, once you say that, it's just, and you say it with authority, people are like, oh, so you can get through.
Mm-hmm. Let's see. Angela White says, are there any resources for clients that can't afford your services? So have you, a lot of times, like in the aging life care field, there are some government agencies and nonprofits that provide those services at a sliding scale rate. Has there been anything like that that's developed?
I would look at senior living, senior places like MSRM, which is Maryland Senior Resource Network. AARP may have people.
And and I will say for cancer, for people that are facing cancer, the American Cancer Society has patient advocates for free in many of the hospitals. They're definitely out there. Services are out there.
Especially like disease-specific organizations.
Yes.
Absolutely.
Yeah, good point. This, because this is a new profession and sort of talking about kind of, okay, what's the difference between a patient advocate and aging life care provider? what you can see is that, you know, perhaps an aging life care professional could also take the certification to become a patient advocate. And Carol Frederick brings up the fact, in the past few years, I've advocated for many residents living in assisted living and memory care facilities. I've also provided end-of-life advocacy. How would you recommend, if somebody is interested in this credential or profession, what would be the steps that they should take to move forward?
I would direct them to those websites, and I was trying to type them in as Dana was talking, but the National Association of Healthcare Advocates and the Alliance of Professional Health Advocates are both amazing organizations. The latter, AFA, Tricia actually has lots of resources, and there are books. You know, she's published at least 3 or 4 books all about how to start a private patient advocacy business. So I would direct anyone that's watching that's interested in learning more about our field to go to one of those 2 or both of those resources.
And I would also say, I'm sure that you two would feel the same way. I'm happy to talk to anybody on this call that like wants to just learn more about how I got it started, and I'm happy to share. Happy to share.
I agree. I will also.
Excellent. Yeah, I mean, I've sort of seen this in the aging life care and the senior move management and the daily money management business. When these new professions sort of are born, there's so much resource sharing and collaboration. And then also the providers that are willing to put themselves out there, like you 3 and some of your other colleagues, you know, they're the trusted providers. It's the ones that are not really putting themselves out there that, you know, oftentimes that we need to worry about. But man, I looked at the clock here and we're 10 after 1. Let me just sort of run through. Wes Morrison has made a comment that the villages are doing patient advocacy on a non-professional level, but there are some trained medical note taking. I think the thing that I like about the direction that your profession is going is there's a lot of people trying to do this, and you know, providing some consistency and some credentialing and some sharing of resources is only going to make things better for the end consumer. Wes also says, in discharge from a hospital, especially for Medicare patients, I think that was more of a statement talking about observation, medical days. Let's see. Okay. I think we've really addressed most of the topics, and we're past 1 o'clock. So this was really exciting to sort of learn about a new profession. For everybody, I've recorded this. I will download the chat and distribute that to everybody. If you guys don't mind, shoot me an email here in the next few hours with those resources that you would like everybody to know about, and I'll make sure to get it out to everybody who registered for today's event.
Thanks, Steve.
Perfect.
Thanks so much, Steve.
Thanks for having us.
Great.
Us.
Thank you very much.
You bet. All right. Okay. See y'all at the next one.